So I'm going to show you case 1 as an unknown here. Case 2, it's the right kidney. Case 3, case 4, and case 5. The first case is a newborn with congestive heart failure. We can see on this chest x-ray that we have a markedly enlarged heart in this baby with vascular congestion, and we also have widening of the upper mediastinum that could just be thymus, but it's not going to be in this case. The differential diagnosis of congestive heart failure in the newborn period can include either a left ventricular inflow obstruction, in which case the heart will be normal sized. Classic lesion for that is an obstructed total anomalous pulmonary venous return. Or you can have a left heart outflow obstruction, and in those cases the heart will be big, and classic lesion for that would be a neonatal coarctation of the aorta. You can have muscle disease such as a cardiomyopathy, and you can have non-cardiogenic causes such as hypervolemia, asphyxia, arrhythmias, metabolic diseases, peripheral AV fistulas. Here's a patient who has a hypoplastic left heart, a left heart outflow obstruction, cardiomegaly, vascular congestion, left heart outflow obstruction. This particular baby that I showed you the first chest x-ray on also was noted to have a cranial bruit, and we can see a hypoechoic mass in the pineal region. Here you can see on the sagittal view above the cerebellum that we have sort of yin-yang, very hyperactive flow in that mass, so it's a vascular mass, and this was a vena Galen malformation, which is an intracranial arteriovenous malformation. You have thalamoperforators, choroidal arteries, anterior cerebral arteries that then anastomose directly to a midline prosencephalic vein. So the blood goes rushing up through this AVM and back down into the chest, and that's why these kids present with congestive heart failure and a wide upper mediastinum. The bad thing for these kids is that all this blood that's rushing through the AVM doesn't go to give the brain any oxygen. Other pineal region tumors that you want to think about when you're thinking about masses in the pineal region would be germ cell tumors, most commonly a germinoma, pineal parenchymal tumors, most commonly a pineoblastoma, which is a type of peanut, gliomas, and malformative tumors such as dermoid or epidermoid. Here's a patient with a pineoblastoma, a solid enhancing pineal mass on the sagittal postgadolinium image, and you can also see the sugar coating of the cord coming down here that is drop metastases. Next case is a child with recurrent TIAs and progressive neurological impairment. Here you can see that there are multiple areas of abnormal T2 signal suggesting multiple prior infarcts. And here's this child's angio showing the typical puff of smoke appearance. We can see the internal carotid arteries, but we don't see middle cerebral arteries or anterior cerebral arteries. All we see are the hypertrophied thalamoperforator vessels and lenticulostriates. And this is Moyamoya syndrome, which is slowly progressive stenosis of the proximal intracranial vessels. The angio I showed you, which you can also see on an MRA, is a very typical appearance. The posterior circulation is very uncommonly involved. Most cases are under 20 years of age. They present with recurrent TIAs and progressive neurological impairment, seizures, and headaches. They may have sickle cell disease. And the treatment is an encephalodural arterial synangiosis, which is basically anastomosis of the extracranial carotid circulation to the intracranial carotid circulation. So the external branches to the internal branches to try to get some blood supply to the brain. Next case is a premature infant with labile blood pressure and respiratory distress syndrome. We have a head ultrasound showing an incredibly premature brain and no sulcation here, but we have abnormal increased echogenicity surrounding the left lateral ventricle, and more posteriorly, again, you can see that increased echogenicity surrounding the ventricle and also increased echogenicity and dilatation within the ventricles. That is a grade 4 hemorrhage. Here's another patient with a grade 4 hemorrhage where you can see on CT the edema surrounding the hemorrhage in the parenchyma. You can also see that there's blood layering in the left lateral ventricle. Here's the same patient by ultrasound, that echogenic mass, and here it is posterior to the trigone on the right on the coronal view. Neonatal intracranial hemorrhage is frequent in infants under 1,500 grams. It can be as high as 43%, and 80% of those are clinically silent, which is why we do screening ultrasounds on these patients. Most patients, if they're going to hemorrhage, do it in the first 3 days of life, so it's reasonable to do your screening ultrasound after 3 days. It may be associated with periventricular leukomalacia, and these patients may end up with hydrocephalus, porencephaly, mental retardation, and actually this is the most common cause of cerebral palsy in the United States now is premature infants. It's also a common cause of non-respiratory death in preterm infants. The grading is a clinical grading, and so what I do is I describe what I see in my body of my report, and then in the impression I'll give the highest grade on each side of the brain. Grade 1 is confined to the subependymal germinal matrix, which is a very friable area of small vessels that are used during the migration of the neurons as the brain is developing, and that it involutes by about 34 weeks, and that's the most common place you're going to see this hemorrhage. Grade 2 is into the ventricle, but not dilating the ventricle. Grade 3 is the hemorrhage dilating the ventricle, not fluid dilating the ventricle that has some blood in it. And grade 4 is parenchymal hemorrhage. Now the problem is you don't have to have a 1 to have a 2, and you don't have to have a 3 to have a 4. So that's why the system is a little awkward from our standpoint. Here's a grade 1 hemorrhage where you're in the caudothalamic groove, and you can see there's increased echogenicity compared to the opposite side. On your sagittal view, caudate thalamus, here's this very enlarged echogenic focus. If there's any question about whether or not this is blood or choroid, put the color Doppler on it. If you see flow in it, it's choroid. It's not a hemorrhage. If you don't see flow in it, it's probably a hemorrhage. Grade 2 hemorrhage into the ventricle, not distending the ventricle. There should not be choroid in the frontal horn or the occipital horn of the lateral ventricle. So if you see what you want to call choroid up in that frontal horn, think about blood instead. Grade 3, here you can see the hemorrhage where the hemorrhage directly is distending the ventricle on both sides. Next case is a 10-year-old with diabetes insipidus. Here we can see a brain MR, and sometimes the hardest thing to remember is that you have to look for what isn't there, and we don't see a posterior pituitary bright spot on this patient. That can be seen with dehydration. It can be seen with diabetes insipidus, but it's an abnormal finding. This patient had a follow-up MR because of continued DI, and now we can see the large enhancing mass in this patient with a pituitary region germinoma. Germinomas account for about 65% of intracranial germ cell tumors. They can occur in the pituitary region or the pineal region, and in the pituitary region you often see diabetes insipidus, emaciation, or precocious puberty. The differential diagnosis of pediatric cellular and supracellular masses is a little bit different than adults. We think about gliomas, craniopharyngiomas, germ cell tumors. We can have histiocytosis, and then some other rarer lesions that I've listed below. Histiocytosis, you usually see thickening and enhancement of the infundibulum and diabetes insipidus. Here you can see this patient who did have histiocytosis with a beautiful example of a floating tooth sign due to the histiocytic involvement of the mandible. Craniopharyngiomas come in a lot of different flavors. They may be more cystic, they may be more calcified, and here you can see a calcified one by CT with associated hydrocephalus. Here you can see a more cystic lesion, and they not infrequently will grow right over the top of the clivus and end up in the posterior fossa ventral to the brainstem. So you have to think about craniopharyngioma with lesions such as this as well. The next is a 3-month-old with a funny shaped head. Here we can see we have dolichocephaly or scaphocephaly, and when we look at our frontal view, we can see a heaped up sclerotic narrow sagittal suture. This is sagittal synostosis, which is the most common form of craniosynostosis. Counts for a little over half. The patients present with scaphocephaly or dolichocephaly because the head can't grow side to side because that sagittal suture is fused, so it grows the way it can, which is front to back. The fusion begins at the mid portion of the sagittal suture and goes anteriorly and posteriorly from there. Craniosynostosis can be primary or idiopathic, or it can be secondary due to part of a syndrome such as Cruzon or Apert syndrome. You'd look for polysyndactyly in such cases. And it can be seen with metabolic diseases such as rickets, bone dysplasias, and if somebody has a real big head and then they shunt them for hydrocephalus and the skull sort of collapses, sometimes it'll fuse prematurely. Coronal synostosis is the second most common synostosis, and the typical thing you'll see on a skull film is a harlequin eye deformity. You can see right here the bone is tethered by that closed coronal suture, and so it's tented there and it can't grow down. They will also have brachycephaly because the head can't grow front to back because that coronal suture is fused, and it's usually unilateral, so the head will be asymmetrical. Topic synostosis, you get triganocephaly, you'll get ridging along the region of the metopic suture, and they'll have like a ship keel deformity, and then they'll have the quizzical eye deformity where it's tethered here so the orbits are pulled up and in. Positional plagiocephaly is a very common lesion. I'll tell you, I've never seen an isolated lambdoid synostosis, but I see a lot of kids for flat heads because they're put on their backs now to sleep, and they'll usually sleep on one side more than the other, preferentially, and that side will get flat. Consequently, we'll get a lot of films, and you'll see that there's patent lambdoid sutures, but they have a flat back of their head. The big clue that I use on this, especially if you have a CT that they'll frequently do on these patients, is if there was lambdoid synostosis, the ear would be pulled back. If there's positional plagiocephaly, the ear is pushed forward. 5-month-old boy with proptosis, we can see that the patient has multiple periorbital masses on both sides, along with bony destruction. The differential diagnosis of orbital masses overall in kids is very extensive. There can be inflammatory lesions, there can be tumor lesions that can be benign or malignant. You can have vascular malformations, you could have bony maldevelopment, and then you can get proptosis from Graves' disease. The patient I showed you with those periorbital masses, the kid actually presented with bilateral ecchymoses or raccoon eye deformity, and here you can see that this patient has neuroblastoma with a calcified mass in the right paraspinous region. This is an incidental pineal cyst. It's not uncommon for patients to present with bony metastases with neuroblastoma, and they may start working the patient up for non-accidental trauma with bilateral black eyes, and you have to realize that, nope, they have a tumor. Neuroblastoma is the most common extracranial solid tumor of childhood and the third most common malignancy in children. It arises from sympathetic neuroblasts, and there are lots of different staging systems. I'll tell you that the newer staging systems that are coming out, that the Children's Oncology Group and the International Neuroblastoma Study Group are looking at, rely very heavily on imaging features. You need to know one, and the Evans staging system is as good as any. But realize that as you go forward in your careers, your clinical colleagues may be coming to you needing very specific questions answered about neuroblastoma patients because their protocols and how they're going to operate on these patients is very dependent upon what we're seeing on our imaging. Other orbital lesions, just to give you some differential examples, here we can see a soft tissue mass with bony erosion of the lateral aspect of the orbit, and this one was histiocytosis. Here's a patient with a preseptal mass. It was actually underneath on the bottom side of the lid, and this was a rhabdomyosarcoma. This patient has an extensive lesion that does extend into the orbit, very strongly enhancing some weird sort of bony septa in it, and this was fibrous dysplasia. Here's a patient that has a large mass centered on the lateral orbital wall, and the big thing I want you to notice is that there's very little evident bony destruction of that lateral orbital wall. And when you see that constellation of findings of the mass centered around the bone, think about a granulocytic sarcoma, because kids will actually often present with their chloroma before they present with abnormal blood levels that they can diagnose the leukemia, and this may precede the diagnosis of the leukemia by several months. The next case is a 3-year-old with a stuffy nose, and you can see that there's pansinusitis. The differential is sinus mucosal thickening. It can be congestive, or, every kid's crying when they get a film done. It can be infective, it can be allergic. I think everybody in the Sacramento area has allergic sinus disease. Cystic fibrosis, connective tissue disorders, but also remember there's things like Cartaginer syndrome. Here we can see that this patient has patchy airspace opacity and has bronchiectasis, has situs inversus totalis. And this is due to deficiency of the Dynein arms of the cilia. It's one of the dysmotility syndromes. It's autosomal recessive in its inheritance. They have chronic sinusitis, bronchiectasis, situs inversus, male sterility, and they often will have associated middle ear disease. Next case is a 9-year-old girl who's complaining that she feels like there's something stuck in her throat. Here's her lateral airway view, and you can see that Dr. Cohen talked that there can be a little irregularity along the posterior aspect of the tongue, but here we see a soft tissue mass sitting above the level of the hyoid bone. And the differential of that would be lymphadenopathy, lingual thyroid, a lymphangioma or a hemangioma or a rhabdomyosarcoma. Here's her CT exam, and you can see that this is a very dense lesion on even non-contrast exam, and it enhances post-contrast. If we look at the region of the thyroid, we don't see any thyroid gland in its normal position. If we do a technetium scan, here we can see the only thyroid that this patient has is that ectopic thyroid at the base of the tongue. So anomalies of the thyroid, you can have agenesis that can be unilateral or complete. We can have an ectopic thyroid, which was our unknown case 1. It's most common at the foramen cecum at the base of the tongue, and it may be the only functioning thyroid. So you need to know that and tell your colleagues that before they go to take that out. You can also have thyroglossal duct cysts, which are midline abnormalities that can occur anywhere from the base of the tongue to the suprasternal region. Next case is a newborn with stridor. We can see there's widening of the upper mediastinum with displacement of the endotracheal tube, therefore the trachea, and the esophageal catheter to the left. When we do an ultrasound, we see a hypoechoic mass lesion in the upper right neck. And we can see that on CT that this is a cystic lesion. The differential of cystic neck and upper chest masses include cystic hygromas, vascular malformations, branchial cleft cysts, thyroglossal duct cysts, suppurative adenopathy, thymic cysts, and duplication cysts. This one was a cystic hygroma, which is a lymphatic malformation, and it results from maldevelopment of the cervicofacial lymphatic system. They're usually evident at birth, but they can enlarge with infection or hemorrhage. Here's an example of a branchial cleft cyst, which arises most commonly from the second branchial cleft. And can arise anywhere from the tonsillar fossa to the supraclavicular region. One of the classic things branchial cleft cysts will do is insinuate themselves between the carotid and the jugular. Here's another patient that has a cervical duplication cyst. You can see the large, at least partially air-filled mass at the left side of the neck, and when we're giving this patient some contrast to swallow, we can see the communication with the proximal cervical esophagus. Here's a lesion on CT with a big air fluid level in it. An 18-month-old with new onset of asymmetrical wheezing. Here we go, inspiration, expiration. I don't think you've seen this before today, where we have forced, I like forced expiratory views because you get both lungs on one view. This lung collapses, this lung doesn't. Foreign body aspiration, it's usually a non-opaque foreign body, such as a piece of a carrot, a peanut, a hot dog, and they usually go into the right mainstem bronchus because that's the straightest shot. It's a ball valve mechanism of obstruction. When they breathe in the bronchus is a little bigger, air can get around it. When they breathe out and the bronchus gets smaller, the air is trapped in there. Little kids are little vacuum cleaners, and remember, especially around a year of age, they're working on their pincher grip, and so they're picking up everything, and of course, everything goes in their mouth. Sometimes, and this is frequent in the trauma patient, you will end up like we see here, where we have a right middle lobe collapse, and if you look carefully, there is a tooth in this right mainstem bronchus. Watch for teeth in trauma patients, especially car accidents, because you'll find them all over the place. Next is a preterm newborn with respiratory distress. Here we see that there's granular pulmonary markings, and this patient is intubated, so we can't say much about the lung volumes because the child is intubated. They're hyperinflated here. My differential for medical lung disease in the newborn is chimp plus TTN. Cardiac, hyaline membrane disease or respiratory distress syndrome, immature lung, meconium aspiration, pneumonia, and then TTN. Now, not all of those fit in the same patient. Obviously, immature lung and hyaline membrane disease are going to be seen in preterm infants, meconium aspiration in post-term infants. But the big reason that I stress this is don't forget to think about cardiac disease. Because remember at the start, I told you those left heart inflow obstructions will give you vascular congestion, which can be mistaken for interstitial lung disease and a normal-sized heart. So you may be the person that suggests that there could be pulmonary vein stenosis or an infradiaphragmatic pulmonary anomalous venous return. Here's a patient with a total anomalous pulmonary venous return that's supracardiac. They have a generous heart, some perihilar vascular congestion. Here's an immature lung. And what immature lung is babies that have been stressed in utero. So you'll see thymic involution. And they basically look like a little bitty adult chest x-ray, only their lungs are a little granular. And the reason that they're that way is that they don't have as many alveoli per cubic millimeter as an adult does. Their lungs are not done growing. Typically, these babies will either not be intubated or require very little ventilatory support, and they typically get off of the ventilator very quickly. Meconium aspiration, again, term and post-term infants. Look for the humeral head ossification centers, which come in between 38 and 42 weeks. Usually you will see them in children that have meconium aspiration. The reason is that you don't get your gasp reflex and poop reflex to stress until about term. So that's why you don't see this in preterm infants. Depending on the character of the meconium, it can be very patchy, it can be very granular. In about 25% of cases, see associated pneumothoraces, but it is very unusual to see pleural effusions. Usually the patients will be hyperinflated. Now, the reason I mentioned the pleural effusions is that one of the main differentials is a pneumonia, often a group B strep pneumonia, and if you see a growing pleural effusion in a baby who has patchy airspace opacity, think about neonatal pneumonia. Transient tachypnea of the newborn is really a retrospective diagnosis. It's delayed or slightly slowed reabsorption of the normal fetal lung fluid after the baby is born. And you will usually see over 24 hours very rapid improvement. I mean, they can have horrible looking lungs up front, big hearts, vascular congestion, patchy airspace opacity. 24 hours later, look normal. Now back to the original case. This was a patient who had respiratory distress syndrome, but I want to point out to you that the PICC line is on the left side, that left arm PICC line. It's almost touching the umbilical arterial catheter. If I can have you remember two things besides midgut volvulus, please watch these PICC lines. They are very tiny lines, and the people putting them in cannot tell that they have put them in an artery. They don't get blood rushing back at them. They can't really transduce these very well, and you can end up with some very bad consequences if there is an arterial position of a PICC line. If there is any question about where a PICC line is, you have two things that you can do that are very easy. One is you can have them draw blood gas and see if it's an arterial or a venous blood gas. The second thing is you can inject a little bit of contrast. But if you have an arterial line and you put pressors in that, you're going to end up with a real problem. Okay, abnormal prenatal exam. Here you can see that there's cystic lesions in the left upper quadrant adjacent to the spleen in this child, but we can see a normal adrenal gland here. The differential diagnosis of cystic left upper quadrant lesions would be a cystic neuroblastoma, a multicystic dysplastic kidney, upper pole hydronephrosis of the left kidney, or a cystic extralobar sequestration. And here on this MR, you can see the cystic and solid mass, and we could not demonstrate the arterial supply. The baby was pretty small, but this turned out to be a cystic abdominal pulmonary sequestration. Now, extralobar pulmonary sequestrations are part of a continuum of pulmonary developmental abnormalities, and the way I like to think about it is that there's abnormal vasculature and normal lung on one end, which is a pulmonary AVM, and on the other end there's abnormal lung but normal vessels, which is congenital lobar emphysema. And in between you have everything else. I think that this works well because a lot of times you'll see more than one of these lesions together. Like you'll see a sequestration that has features of a CCAM or CPAM in them. You know, they're not often pure. Classically, an extralobar pulmonary sequestration has no normal connection with the bronchial tree, a separate pleural covering, an arterial supply from the aorta and venous drainage back into the azygos or IVC, most common lower lobe, usually on the left. 65% have associated anomalies, but those anomalies are usually something related to that left diaphragm. The lesions can be above, in, or below the diaphragm. And they're due to an accessory lung bud that occurs during the first 5 to 7 weeks of gestation. Here's the normal lung bud, here's the accessory lung bud. And depending on where this comes off, and the level of attachment it maintains, you can account for pretty much all of the bronchopulmonary foregut malformations, esophageal duplication cysts, bronchogenic cysts, et cetera, et cetera. Next case is a newborn with an abdominal mass. We see a huge mass displacing bowel to the left. One clue I will give you is that non-bowel masses in infants will displace the bowel but not obstruct it. Bowel origin masses will obstruct the bowel. When we look at this lesion, it's a very complex lesion. It has an area of either hemorrhage or necrosis within it, huge mass. And this turned out to be a mesoblastic nephroma. Here's another patient, more recent, with a mesoblastic nephroma that you can nicely see arising from that right kidney. This is a fetal renal hamartoma. It's usually benign, but it can metastasize, and it can very rarely degenerate into a malignant spindle cell sarcoma. And it's the most common renal tumor in neonates. If you see something that you want to call a Wilms tumor and the baby is under 10 months of age, call it a mesoblastic nephroma. Abdominal masses in neonates are usually benign and usually arise inside Gerota's fascia, either from the kidney or from the adrenal. The kidney lesions account, out of all abdominal masses, account for over half, and the most common are the hydronephrotic lesions as a group, so UPJ, UVJ, blah, blah, blah. But the single most common lesion is the multicystic dysplastic kidney. Other things that you can see I've listed here. Multicystic dysplastic kidney, as Dr. Daldrup-Link showed you, non-communicating cysts in this patient's left entire abdomen. And you can see on a DMSA scan that we see no functioning left renal parenchyma. Again, a giant mass displacing bowel over to the right in this particular case. Genital masses can either be hydrometrial colpos or ovarian cysts. You remember in that last talk when I was talking about cystic right upper quadrant masses, I listed an ovarian cyst, and here is an example of that. Here's the right kidney, here's the liver. Remember, a baby girl's pelvis is very small, so if they get even not a real large ovarian cyst, it'll be displaced up into the abdomen, often into the right upper quadrant, and this one is hemorrhagic. Gastrointestinal masses, duplication cyst, mesenteric or mento cyst. This is a big mesenteric cyst. Complicated meconium ileus account for about 15% of abdominal masses in neonates. Non-renal retroperitoneal, the other adrenal lesions, adrenal hemorrhage or neuroblastoma account for about 10%. This patient has a mass in the right upper quadrant, and here we can see this is an adrenal hemorrhage with a complex mass superior to the right kidney. I don't know why this kid got a CT scan, but they did, and here you can see the hypodense mass above the level of the kidney. Neonatal adrenal hemorrhage is usually an asymptomatic flank mass in a child that's been shocked. Somehow they may have anemia and jaundice. That shock can be birth trauma or stress or infection. The big thing you want to do is exclude that you have a neuroblastoma, and you do that by following the lesion to its resolution, where you'll end up seeing a little calcified adrenal gland. So if you have a lesion that you think may be a hemorrhage, follow it up until it's gone to prove you don't have a neuroblastoma. Hepatobiliary masses are actually pretty uncommon in neonates. The most common is metastases, usually from neuroblastoma. The primary intrinsic liver masses are hemangioendothelioma and hepatoblastoma. And I've already shown you some mesenchymal hamartomas and choledochal cysts, unusual to present in the neonatal period. Hemangioendotheliomas can be single or multiple. They're hypercellular tumors and AV shunting. They proliferate during the first 18 months of life and then involute. The patients may present asymptomatic with just liver enlargement, but because these are shunting lesions, just like that Vena-Galen malformation, you may end up seeing congestive heart failure, you may see anemia and jaundice, and you may see platelet sequestration within these lesions. That is the Kasabach-Merritt syndrome. The main differential is hepatoblastoma. The thing that you can try to use to help you is, number one, do you see shunting? Hepatoblastomas are not supposed to shunt, so you shouldn't see the aorta getting much smaller just beyond the takeoff of the celiac and SMA. You should not see big draining hepatic veins. The other thing is the AFP level. The AFP level will usually be sky high in a hepatoblastoma, and babies have mildly elevated AFP levels, so in a hemangioendothelioma it should be not. Here's a 14-year-old with a history of back pain, and he had neuroblastoma as an infant. You can see he has multiple renal masses on this CT that are hypodense with respect to the normal kidney. By MR post-GAD, you can see that he has multiple lesions. And this is renal cell carcinoma after treatment for neuroblastoma. And I bring this up to you guys because a lot of you are going to be adult radiologists, and I think as we have more and more children surviving their initial cancer, even high-stage cancers, we're going to start seeing second cancers much more frequently. This appears to be a distinct clinical entity. It can be seen 2 to 20 years after the treatment for neuroblastoma. It's often bilateral, and it's not associated with the location of the tumor. I've seen these come from with primaries up in the neck of neuroblastoma. It's not related to the radiation therapy or the chemotherapy. There's been one patient that had a neuroblastoma and then a renal cell carcinoma and then a pheochromocytoma in the literature as well. In older kids, again, most abdominal masses remain inside Gerota's fascia, but our differential changes to where the tumor lesions move up in the list as far as the chance of them happening, and Wilms tumor is our big one. You can still have hydronephrosis, you can have cystic renal disease, as Dr. Daldrup-Link talked about, and other lesions here. Case 2 was a Wilms tumor where you could see this mass hanging off of the right kidney. It's the most common renal and abdominal tumor in the US, but remember that even with that, there's only about 500 new cases in the United States each year. So when you're training and you're at a center, you're seeing all the cases from a large catchment area. It's an intrarenal mass. Here you can see the claw sign. And the big thing for you to do is try to figure out the extent of this tumor. Where's the primary tumor? Is there vascular invasion? Here you can see on this ultrasound that the tumor is growing from the left renal vein into the IVC. Is there involvement of the opposite kidney? And is there metastatic disease that most commonly occurs to the lungs and then to the liver? Now the staging, you can't completely stage it unless there's metastatic disease because it's a surgical staging system. Stage 1 is tumor limited to the kidney and removed. Stage 2, the tumor extends beyond the kidney but is completely removed. Stage 3 is usually cases where they ruptured the tumor trying to get it out, things like that, or if it's grown into the vasculature and they can't get it all out of the vasculature. Stage 5 is bilateral renal involvement initially or during treatment. There are a lot of associations with Wilms tumor, so you may be doing screening ultrasounds for patients every 3 to 6 months for things like sporadic aniridia, a huge association with Wilms tumor, hemihypertrophy, Beckwith-Wiedemann, and other syndromes that I've listed there for you. Now, nephroblastoma is another lesion that is a precursor to Wilms tumor. Here you can see this lobular nodular coating of the kidneys. This is normal enhancing parenchyma on this MRI, and here you can see on the ultrasound that there's like all this hypoechoic material that's coating and pancaking the tumor. This is persistent foci of metanephric blastema after 36 weeks of gestation. There are 3 phases of it. It can be dormant, it could be regressing, but the big part we're worried about are the hyperplastic lesions. And as Dr. Daldrup-Link mentioned, you want to see that these lesions are homogeneous. If they're not homogeneous, you start thinking about the worry of conversion to Wilms tumor. And MRI is a fabulous way to follow this lesion. They're T1 hypointense, T2 hyperintense, and as they regress, they become fibrotic, so you can watch them become dark on T1 and T2 images. They enhance less than the normal tissue. So again, if you see them becoming inhomogeneous, worry that you have transformation. Multilocular cystic nephroma, benign cystic mass, multiple septi. There's a bimodal distribution in young boys and older women. Lymphoma, I will say that I had on my boards, and I've heard multiple times on boards, that they will show lesions that they want you to say are cysts, and they're not cysts. Lymphoma can be hypodense, hypoechoic, and not be a cyst. So don't forget that differential. It can present in the kidneys as a single renal mass, multiple masses, diffuse infiltration, or an extrinsic mass. And here you can see multiple renal masses and also involvement of the pancreas. Rhabdoid tumor is a really bad player. It's a highly malignant and fatal neoplasm. It's rare over 5 years of age. It's in the differential for Wilms tumors, and you don't want to have to diagnose it. Again, if you see skeletal metastases, brain metastases, as in this case, think about rhabdoid tumor as opposed to Wilms tumor. Non-renal retroperitoneal account for about a quarter. Again, that's inside Gerota's fascia, the neuroblastomas. You can also have rare retroperitoneal rhabdos. Gastrointestinal and biliary lesions, appendiceal abscess, intussusception are common. Outside the idiopathic range that I told you about before, 3 months to 2 years, if you see intussusceptions, think that there's some other reason than the idiopathic intussusception. Usually under 3 months of age, there's some kind of a lesion there, like a Meckel's diverticulum. Older than 2 years, think lymphoma. Very, very frequently, that's what you'll see. And here's a patient where you can see their cecal intussusception, the marked bowel wall thickening, and this was Burkitt's lymphoma. Next case is a 10-year-old with abdominal pain. We can see that there's a left mid-abdominal soft tissue mass that's hypodense, but has some rim enhancement. As we come up into the upper abdomen, we can sort of see this whorled appearance. When we get to where we should see the spleen, we see no spleen. And this is torsion of an ectopic spleen. The supporting ligaments of the spleen or lax are absent, and it allows the spleen to twist. And the CT findings are just what I showed you here. I've seen this more frequently in patients that have heterotaxy and things like that. Other splenic abnormalities, you can have asplenia and polysplenia with the heterotaxy syndromes. Now, I will tell you, it makes your life much easier if you're examining a baby for heterotaxy and you're trying to find out if they have a spleen or not. If you're going to find a spleen, it's where the stomach is. So if the stomach's on the right, look on the right. If the stomach's on the left, look on the left. If the stomach's midline, look midline. You can have accessory splenic tissue very frequently. The spleen can be ectopic. You can have vascular malformations. And then all the causes of splenomegaly and, of course, trauma. The next case is an 11-year-old with hemoglobin SC disease and abdominal pain. He has markedly elevated pancreatic enzymes. Here's his CT, and you can see that he has dilatation of the pancreatic duct, but he also has all this filling stuff in his stomach. Here is his post-surgical specimen, and you could see that this trichobesor went all the way around into the duodenal sweep, and so it was obstructing his ampulla of Vater, which is why he got pancreatitis. And this was due to pica. He was eating carpet and doll hair and human hair. Interestingly, pica is very prevalent in patients with sickle cell disease. About a third of all patients will have it sometime during their life, and it may be from iron or zinc deficiency. This particular patient had a zinc deficiency, and his pica stopped when he got his zinc deficiency treated. Next case is a 3-year-old with bloody diarrhea, and you can see a beautiful example of thumb printing along the transverse colon, so submucosal hemorrhage or edema. The same patient had hyperechoic kidneys, ascites, and had very severe. The baby ended up dying, the child ended up dying, hypodensity due to basal ganglia infarction, and this was due to hemolytic uremic syndrome, which is the triad of acute renal failure, microangiopathic hemolytic anemia, and thrombocytopenia. It's not uncommon for the children to present with colitis before they present with their renal disease. They can have rhabdomyolysis, they can have diabetes. It's usually in the 1 to 5-year-old age range, and people think that there's an infectious stimulus, but it may be an endotoxin. That endotoxin leads to vascular endothelial damage. You get fibrin strand formation, damage of the red cells, and then you'll end up with vascular congestion and thrombosis, and that's how you end up with the renal, the CNS, and the GI lesions. The next case is an 18-month-old who stopped walking over several days, and if you look at this lateral view of the spine, it's a subtle abnormality, but the patient has disc space narrowing at L4-5. On MR, you can see that he has marrow edema at the L4 vertebral body, and he has enhancement, and actually also a small soft tissue enhancement or inflammation, and this is discitis, which is usually a staph infection seen in the child under 5 years of age. They tend to refer pain away from their back, so you always have to, when kids say a joint hurts, you have to often look one joint distal and one joint proximal if you don't see anything where they say it's hurting. So if they say their hip is hurting, you don't see anything, look at their knee and their back. If they say their knee is hurting, look at their hip and their ankle. And the radiographic findings are, as I showed you here, disc space narrowing, which on the plain film may be rather subtle. At MR, you'll see contrast enhancement of the disc and vertebral body and marrow edema. The next case is a newborn infant, has pain when the nurses move his arms and legs. He has a hypoplastic left heart. Again, you see big heart vascular congestion, but like Dr. Patel showed you, here you can see very dense, thick periosteal reaction along the clavicles, the humeri, and even the ribs. And the differential of periosteal reaction in infants can be physiologic. Now, physiologic is just due to rapid growth, and it's seen in the first few months of life. Now, the thing that you will use to call physiologic periosteal reaction is that it is symmetrical and it is proximal. It's usually the humeri and the femurs. If you have isolated tibial periosteal reaction, that's not physiologic periosteal reaction. If you see it more distal, you'll have to see it proximal first. You can have infection or inflammation. You can have metastatic disease, trauma. Dr. Patel showed you an NAT case, a non-accidental trauma. You can have metabolic bone disease and Caffey's disease. This was another case of prostaglandin-induced periostitis. In ductal-dependent cardiac lesions, they'll use prostaglandins to keep that duct open until they are able to do the corrective surgery on these patients. The prostaglandins can cause bone reabsorption, which is probably why they get the periosteal reaction. The periosteal reaction is not dose-related, it's not duration-related, it's irregular, it's asymmetrical, and it's painful. It goes away, though, when you stop the prostaglandins. Some other causes of periosteal reaction, here you can see metaphyseal irregularity and lucency along with periosteal reaction in this patient with neonatal osteomyelitis. Again, another classic metaphyseal lesion, bucket handle fracture in this patient with non-accidental trauma with periosteal reaction. Next case is a 3-year-old with hearing loss. We have very dense bones, and I think this is a beautiful example of a bone within a bone in the iliac bones here bilaterally. And this is osteopetrosis. This is a complex disease. There's multiple types, but these patients have typically will have hepatosplenomegaly. They may have extramedullary hematopoiesis because the bone that's formed crowds out the normal marrow, and also the bone that forms, even though it's very dense and it's due to osteoclasts not reabsorbing the bone normally, is like chalk and it's very brittle. They often will have encroachment of the foramina at the base of the skull, resulting in blindness and deafness. The next case is a young man that's short and has a waddling gait, and we can see here that he has platyspondyly and also has small and irregular epiphyses, flattened epiphyses, and this is spondyloepiphyseal dysplasia tarda, which is an X-linked recessive disease. It usually becomes evident at 5 to 10 years of age. They have flattened epiphyses, they get premature osteoarthritis, and they'll have platyspondyly. The thing to think about in these patients, and a lot of skeletal dysplasias, is the odontoid okay? Because often these patients will be undergoing orthopedic procedures, and before they undergo their anesthesia, you want to make sure they're not going to have abnormal motion at that C1-2 level when they're getting induced. Next case is an 11-year-old girl with short stature. I know you guys hate the ideas of skeletal dysplasias, and but they are more common than cardiac disease in the pediatric population. Make sure you know the name TABI for the book. If you don't know what a dysplasia is, then you could say, well, here's where I'm going to go look to try to figure out what it is. And he has the classic Bible on skeletal dysplasias. This patient had delayed skeletal maturation and has a shortened fourth and to a lesser degree third metacarpal. The differential of a short fourth metacarpal, it can be a normal variant. We see it very frequently, but it can be seen with Turner syndrome, pseudo or pseudo hypoparathyroidism, acrodysostiosis, multiple epiphyseal dysplasias, and it can be acquired from trauma or juvenile chronic arthritis. This case was a case of Turner syndrome, 45XO. It's seen not infrequently. They have short stature, webbed neck, association with cystic hygromas in the neck, and also association with coarctation of the aorta, aortic stenosis, and horseshoe kidneys. Here's a case of pseudo-hypoparathyroidism where not only the fourth, but pretty much all of the metacarpals are short, and you can see that there's heterotopic calcification from the abnormal phosphate deposition. Next case is a 3-year-old who's refusing to walk. We can see there's a very dense sclerotic left iliac bone, and you can see that there's an associated soft tissue mass displacing bowel to the right. Here's this patient's CT where you can see this very aggressive bone lesion with a huge soft tissue mass and bone formation within the mass. This is a Ewing sarcoma, which is the second most common primary bone malignancy in children. But if you see a child that's under 10 that has a primary bone malignancy, you think about Ewing's. Typically, osteosarcoma is not seen till after 10. It's the 10 to 20-year-old range that you start to see that. It also, Ewing sarcoma arises in the extremities, most often in the femur, but also arises in the flat bone, which is less commonly seen with osteosarcoma. You typically don't see pelvic involvement, rib involvement with osteosarcoma, but you do with Ewing sarcoma. If they are metaphyseal lesions, which they frequently are, Ewing sarcoma is, it tends to be eccentric, where if it's diaphyseal, it tends to be central. And the main differential for diaphyseal lesions in the bone in children is Ewing sarcoma, lymphoma, and histiocytosis. The lesion in Ewing's can be very variable. It can be extremely lytic, it can be very dense. When you do an MR on these patients, you usually see a very large soft tissue mass for the level of bone involvement. Next case, painful right flat foot. Dr. Patel mentioned this case, this history, and here you can see that there's a talar beak compared to the opposite side. And on our Harris view, we can see that we don't see the subtalar joint by CT. We can see bony fusion of the subtalar joint compared to the opposite side, and this is a subtalar coalition. Tarsal coalition can be fibrous, cartilaginous, or osseous, and it's seen in 1 to 2% of the population. It's bilateral and up to half. It can be asymptomatic, but the classic history is a painful, spastic pes planus. Their calcaneonavicular and talocalcaneal are about half and half. The talocalcaneo you need to diagnose with a CT scan frequently. It's hard to see the continuous C. You look for the talar beak to clue you that it might be there. But the calcaneonavicular, a plain film works just fine. And here you can see that this patient has a bony on one side, calcaneonavicular coalition, and either fibrous or cartilaginous on the other side. My last case, because I'm going head to toe here, I'm at the toes, as macrodactyly. The differential of macrodactyly will be macrodystrophia lipomatosa, and you look for excess fatty deposition in the soft tissues with that, neurofibromatosis, or vascular malformation resulting in digit overgrowth, and that can be either a hemangioma or Klippel-Trenaunay-Weber. My last couple of seconds, it's been alluded to in the talks all afternoon, and that is dose reduction in the pediatric population. I was just talking to our physicist, and there's new data coming out that since 1980, the amount of medical radiation in the United States has increased 7-fold. So what we're doing now is going to be seen in the future in terms of how this radiation is affecting our population. We need to practice dose reduction in children because they are the most radiosensitive. There is a wonderful website that I've listed here for you, imagegently.org, that has specific ways, especially in CT, to decrease radiation dose that is not vendor specific, that they can tell you, so wherever you go, you'll be able to make sure that you're using low dose techniques on your pediatric patients. And do whatever you can to reduce the radiation dose in kids. Obviously, the best way to do it is to not do the study, but that requires you talking to your clinical colleagues and really working through the case. You can then choose alternate imaging modalities such as MRI or ultrasound as opposed to doing radiographs. And then if you're going to do the study, do it right, do it low dose, and get it done the first time so you don't have to keep going back and re-imaging kids.